And Ben, how important then, we look at, again, just the general population and sometimes like to compare and contrast between, an athlete or professional athlete. And in this instance, I would think of, an offensive or defensive lineman in football who has, the muscularity and aerobic fitness that when we look at their profiles, despite being, carrying more fat mass, particularly around the midsection, their metabolic profile looks terrific. For the most part, and when we look at the general population, if we don't have a level of fitness, if there's a lack of activity and exercise, we really start to see an acceleration of everything we've talked about here. So, can you talk about the role of aerobic fitness and how that can be a part of the solution in some of these scenarios?
Yeah, so I think this is such a neat point. And just thinking on the fly here, I would say that when we look at, I bet there's probably a pretty big distinction between those same players, the big football players on the offensive and defensive line, the linemen, when you compare like high school level to college
100%.
level to professional level,
Yeah.
I would be certain that part of what predicates whether the athlete is good enough to move on is that is a body that can get fatter and stay healthier, as opposed to most of the high school kids that play linemen. They're just, unfortunately, fat and unhealthy. And it's only those ones that have the ability to store more fat and maintain good insulin sensitivity that are able to be kind of fatter and stronger and thus move on up through the ranks, going to college and then to professional. So a distinction between those two, and Mark, I'm not sure if this was where you intended it to go, but I'm gonna go anyway.
Yeah, you do.
Part of the difference is probably that the majority of those fatter linemen, high school kids that aren't healthy and that aren't going to move on in their career despite their best efforts, they're probably getting fat and insulin resistant. And as the body becomes insulin resistant, it does compromise muscle growth. Insulin defends muscle. I think it's more accurate to say it that way. Insulin doesn't necessarily promote skeletal muscle protein synthesis, although it's certainly relevant to it. You need insulin there, but spiking insulin doesn't appear to facilitate that. And I say that with some degree of confidence because we know in adults, when you give an adult after workout a protein load, there will be an expected increase in muscle protein synthesis. When you give them protein and carbohydrate, you get no additive effect. There's nothing beneficial about increasing the carbohydrate and the insulin following that workout. It doesn't have an additive effect. So back to my point, insulin doesn't really need to be spiked to promote muscle protein synthesis, but it is necessary to defend muscle protein synthesis. So it defends the protein that the muscle has already made. But if you're insulin resistant, you've lost that protective effect. Insulin can't protect the muscle as well. So in these high school kids that are linemen and fat, the ones that get washed out are likely the ones who are sick because of their fat, as opposed to the people that can become elite, but that is a subset of the population. As we both know, that is a very rare achievement to be able to go on to those levels. Those are the guys who can be fat and still be insulin sensitive and metabolically healthy, and that very likely boils down to the nature of their fat cells. In other words, is the fat cell sick or is the fat cell healthy despite being, having more fat? And on the sick side of things, that is when fat tissue is growing, like the overall tissue, the belly's fatter and bigger and bouncier.
Yep.
Because the individual fat cells themselves have grown. In other words, they have hypertrophied. And that's, of course, a term that any of your athletes would know. When we think about muscle cells, a muscle grows because it hypertrophies. But that's a good thing in the muscle. It's not a good thing in fat cells. A hypertrophic fat cell becomes insulin resistant. And that's typically where it starts. If someone has insulin resistance, it's very often going to be because the fat cells became insulin resistant first because of genetics and partly diet. They grew through hypertrophy. And in contrast, we have some people in the population, it's a minority, where they are able to continually recruit new fat cells. And so they have, when a fat cell starts to get a little big, before it gets too big, it kind of recruits a new fat cell to help share the load. then that fat cell can start to get a little fat. And so no fat cell ever gets too big. And in so doing, they stay very insulin sensitive. And so insulin is in control, and the muscles can continue to grow and be strong and defend their protein. So probably at the root of at least one of the differences between the high school lineman and the elite level lineman is the degree to which their fat cells undergo hypertrophy or hyperplasia, which is the term to describe a higher number of cells.
Yeah, it's fascinating, and in particular as well, once those careers come to an end, as those outliers, as we talk about, those elite linemen become deconditioned and stop the aerobic exercise and the resistance training and whatnot, and start to lose muscle mass, then a lot of what you described, or some of those downstream effects, negative effects, start to take shape. And
Yep, that's an excellent point. In fact, you're bringing it back around to the point you were kind of, I think, hoping I'd make earlier. Yeah, when you are working a muscle, you immediately you have immediate improvements in insulin sensitivity, and part of that is because muscle is such a consumer of glucose. Muscle eats glucose exceedingly well, and so if someone has not only more muscle but they're working it more often, then insulin and glucose levels are much more likely to stay in control over the long term. And then, of course, as those muscles stop working, then all of a sudden you've lost that glucose sink, that glucose disposal. Now glucose is staying elevated for longer, and that means insulin's going to stay elevated for longer. And then you've certainly started flipping the switch towards illness.
Yeah, it's a tricky one when they don't adjust the fuel intake after that expenditure really shifts in post-career. And then, you touched on there, obviously, the fat cells enlarging. And of course, if we shift gears back to the general population, someone who's diabetic and obese, taking insulin, I've heard you talk about the effects of insulin on fat cells and to that point of enlargement. Could you talk a bit about that and how it then trickles down into these hypoxic states that then influence how well that fat cell works?
Yes. I'm thrilled you're bringing that up. Yes, so insulin is an absolutely essential signal for fat tissue to grow. So when you look at the sick fat person versus the paradoxically healthy or relatively healthy, metabolically healthier fat person, what they have in common is that insulin will be elevated. And insulin, again, is what's essential to telling a fat cell to grow. So whether it's growing through hypertrophy or hyperplasia, insulin would have been relevant to both of those instances of growth. And then there would be some other kind of fine tuning or other variables that would have determined whether it was through hypertrophy or hyperplasia, the sick way of getting fatter or the healthier way of getting fatter. But in the case of insulin stimulating fat cells towards hypertrophic growth, part of why that hypertrophic or really fat cell becomes sick is that it essentially starts to reach the physical limits of its size and its proximity to capillaries or the blood vessels. Those capillaries, the blood vessels that actually flow through the tissues, including fat tissue, that is a cell has to be close enough to that capillary to exchange gases and to exchange nutrients. And so, for example, it needs to be close enough to give its CO2 off into the blood and to take in oxygen. It needs to be close enough to share its fatty acids with the blood to be used and to pull in new fat or pull in new glucose. So it needs to be close enough to a blood vessel to survive. When the fat cells are getting too fat, they're getting further and further away from blood vessels. They're relatively deficient in blood vessels, and that is not a phenomenon we see with hyperplasia. In hyperplastic fat growth, there's still an enrichment of capillaries. The cells are never too far from blood vessels. Mm-hmm. And so part of what the fat cell is doing to survive is it's releasing these pro-inflammatory hormones called cytokines. Some of these cytokines are actually essential for promoting the growth of new blood vessels. One in particular is called vascular endothelial growth factor, or VEGF. And it is a pro-inflammatory cytokine, but in the case of the fat cell, it's doing this. It's releasing it in order to try to increase the blood flow. It ultimately fails at this attempt. But it's almost like we have to look at that and kind of be forgiving of the fat cell, you know. And I appreciate that I'm being a little silly in how I'm describing this, but it's basically like the fat cell is becoming it's becoming insulin resistant. The fat cell, it's becoming insulin resistant in order to try to stop its growth. It's basically telling insulin, you want me to continue to grow, but I can't. And so I have to become insulin resistant to you, otherwise I'm going to explode. I'm going to be too fat. And so I'm going to become insulin resistant. And in so doing, it starts leaking fat when it shouldn't, because insulin would normally tell a fat cell to not break down its fat. So this fat cell that's hypertrophic is leaking fat, and at the same time, it's leaking these pro-inflammatory cytokines in an effort to increase blood flow, again, in an effort to survive. And so as the fat cell is trying, the hypertrophic fat cell is trying to survive, it's leaking free fatty acids and pro-inflammatory cytokines, both of which start to result in insulin resistance in other tissues like the muscle and the liver, the blood vessels, the brain. And that's where you have basically the fat cell is the first domino to fall with regards to insulin resistance, and the other tissues are the subsequent dominoes that first one bumps into.
Yeah, I mean, it would seem obviously that using insulin as a therapy should be sort of an acute-based or a transitory medication that's used to try to get somebody out of this state versus what we often see, which is people who are taking insulin, years and years and decades.
Yeah, in fact, I'll go even further. Then I'll be less diplomatic than you are. I'll be distinctly un-Canadian for a moment.
Nice, go for it.
And be less diplomatic. My U.S. roots are rubbing off on me now.
Awesome.
I think it's terrible. In fact, I think it's a horrible clinical practice to give a type 2 diabetic insulin therapy. If it's truly type 2 diabetes, insulin is still elevated, even in the instances when it starts to come down a bit. It never comes down to normal. It's always elevated over normal, and you're giving more of the molecule that's causing at least much of the problem. So let me kind of back up. Much of insulin resistance is a result of elevated insulin itself. So I'll flip that around. Increased in chronically elevated insulin is part of the cause of insulin resistance. We can determine this in humans, and we can determine it in animals and even cells, actual just individual cells. When there's too much insulin, the cells start to become resistant to insulin. And in the case of the type 2 diabetic, the body has become so resistant to insulin that insulin can no longer stimulate the muscle to pull in enough glucose. And so glucose levels start to climb. And that's when we detect the problem as type 2 diabetes. But it's important to then not forget how it started, which was elevated insulin. Too often in conventional medicine, we only look at the glucose level, and we have no regard for what insulin levels are. We have no idea. And we don't even care in conventional medicine. And thus, with that glucose-centric paradigm in mind, it's not surprising that the clinician, the physician, the well-meaning, well-intentioned, will be only looking at the glucose and will say, well, your glucose is elevated, so let's just push your insulin up, little realizing that the person's already swimming in a sea of insulin. And by giving them more insulin, you do lower their glucose, but you are making them more and more insulin resistant. That's why you see that the dose of insulin has to continually go up over time. And you make them fatter. They'll gain about 20 pounds, over 10 kilos in the first 6 months usually. And you make them sicker. The more insulin that the type 2 diabetic is taking, at these higher levels to aggressively lower glucose, they become significantly more likely to die from cancer, heart disease, and Alzheimer's disease. So by treating the type 2 diabetic with insulin, we make them fatter and sicker, and we kill them faster. That is proof positive that this is not a glucose disease, because all of that happens with normal glucose. It's because we are pushing the insulin to ludicrous levels in order to keep the glucose in check. But we do. We keep the glucose in check, and they die faster. It's because that's an insulin problem. And treating type 2 diabetes with insulin is like treating alcoholism with another glass of wine. we are giving them too much of the very thing that's causing the problem.